Oh, I can.
Okay, perfect. Okay, so for all of those of you who haven't met, I'm Danielle Hopper. I'm the clinical field specialist with Edwards. So this will be pretty quick. I've updated most of the monitors. I have a few more to go today, but they're just going to look a little bit different. So once you turn on the monitor, this is what it's going to look like. You don't need to enter a patient ID. It doesn't actually save data in our monitors, so don't worry about putting in a medical record. So you'll need to enter height, weight, age, gender, just like before. Your toggle is a little bit different. So if you have inches or centimeters, you would just toggle between the two. And then your weight, and then we're going to hit next. So it's going to give you the option of Swan or FlowTrack. So I'm going to start with Swan, start monitoring. So it does look a little bit different. This screen, of course, if you guys have met me before, I'm a big fan of the trend screen, but we'll go over how to change things. So just like before, your start is in the top left. So you'd hit start monitoring. I think I should have some numbers that are going to pop up here. So this button right here, it's really, you can set goals for your patient and it graphs them out. I have never seen an ICU use this one. Same as this one, you're not going to use that really for how you guys monitor your patients. If you're on this graph screen, this is the only one you can actually mark interventions, which is actually pretty cool. So you can actually click the little dial with the arrow, and then you can drop down a little marker, and then say your patient changes, or you're trying to see if your volume helped the patient. That's a good thing to do. Let me make sure I have some numbers you're going to get back here. Hold on. Yeah, we'll get some numbers, I think. I'm used to using FlowTrack, so it pops up a lot faster. Okay, so that's just how you would mark interventions on this. So right here is where everything is going to be from here on out. So you have your silence, that gives you 2 minutes. This gears are your settings. Once you click on that, this is going to be kind of your home base. So the clinical tools bag used to be on the side. It still has everything that you're going to use. So Venusox Symmetry Calibration is where you're going to go to do an SVO2 Swan. So you guys should have cables for every monitor. We did find them, I think, all yesterday. So I'm just going to quickly go over it because I know a lot of you haven't used it quite yet. So if you hit Venusox Symmetry, when you do this, you've already clipped in that plastic piece on the new Swan into the cable. Most of the time, you're going to do Nvo Calibration. So this is when the Swan is already in the patient. Say they're coming up from surgery, it's already inserted. In vitro, you're only going to do if you haven't floated the Swan yet, you haven't flushed it or anything. So think in vitro tray. This is when you would use that one. So when you click Nvo Calibration, it'll give you a 25-second countdown. And then you're going to draw. You need an SVO2, so you're going to have to draw an SVO2 from your patient. Enter what your value is and your hemoglobin, and it's going to calculate a hematocrit from that, or you can put in your hematocrit, it doesn't matter. Hit calibrate. So after that countdown, as long as you have oh, hold on. I need to silence all my alarms here. I'm going to say I've never had a fault in a simulation, but we'll see. So your value should pop up in this SVO2 as long as you have it pulled up. So there you go. In the bars now, so before on your monitor, it was like 1 box was a great signal and 4 it turns red, it's a bad signal. So it's more like a cell phone now. So like this is the best signal you're going to get. You'll have fewer bars, and I believe it'll go yellow and red if you don't have as many. So a couple things on the screen that you don't have, because this is an even newer one. So this fluid responsive test is only going to be on FlowTrack for you guys. And this patient data is going to be up here. So patient data, you're just going to want to go there. Say you don't believe your information. I'd check your height and your weight to make sure it was entered correctly. And then you can just hit this back arrow at the top to get out of any of these screens. Mostly that's it for what you guys do at Park West. So to change your screens, we're still in that settings tab. The Select Screens tab is next, and then you can change what you're looking at. So there's your dial screen. So you even have less on the side in this version. You're just only going to have a snapshot in time rather than a trend of your parameters. So this right here, it's a little bit different for you guys right now. It doesn't look like that. It looks like that. So that's your only option right now. Don't need it. If you guys have tissue oximetry, that's when it would look a little bit different like that, so that you can monitor everything. But right now you guys just have the heart screen. This one you do have, so it's going to give you the most parameters. So if you're doing a Swan, you probably don't need 8 parameters. I've seen people do like CO and CI and then the stat. So before, when you guys changed your parameter, you had to click like outside of the box or inside of the box. You can click anywhere to change what you're looking at, and it pops up like this. So if you need to change your parameter, or if you're going to change your alarms, things like that, that's going to be the next one we'll cover. So I don't know if all of you know the difference between cardiac output and then the stat cardiac output. So cardiac output is going to be an average of 8 minutes. Your stat cardiac output is going to be a 1-minute snapshot. So if you have stat cardiac output, that's like if you were shooting a bolus, basically. So stat cardiac output, you're going to have 1-minute snapshots. And then if it's just cardiac output or index, that's an 8-minute average. So if you have a post-op patient, this is kind of nice. It comes up faster. It doesn't come up in a minute, but it's going to give you a few extra minutes ahead of time than if you had the one that's averaged. Or if you're increasing your drips, things like that, you're going to see your cardiac output change and index a lot faster if you have the stat pulled up. Okay, but this is where you would go to change things. So set targets, you can change your limits. If you don't want to see yellow or red, you can come in here and change your parameters on your alarms so that it's not flashing red at you all the time. So this right here is how you're going to silence the whole parameter. So if I just click that, my whole parameter is going to be silenced, and I end up doing it for all of them, honestly. And then everything is going to be silenced until you unsilence it. With that being said, though, if you turn the monitor off, it's not going to be silenced for the next patient, just this patient, until you either change parameters or unsilence it. It's just nice sometimes to silence it when you know it's, that patient just has a poor number and it's just going to stay that way. So now that I have these markers up here, when you actually have to hit the screen with 2 fingers to do this, but once you do, you can actually look at your percent change and move these little cursors, which is nice. So if you're ever dropping your interventions, that little triangle, it's kind of nice to see the change over time in your patient. What kind of questions do you guys have? It's pretty user-friendly. You shouldn't need to be in settings, really. And then help, that's if you have some alarms or some faults, you can go in here to figure out what it is, or you can just call me, one of the two. Do you guys have questions on Swan before I go into FlowTrack?
This may be a question for Donita. Do we know if the surgeons and like the cardiologists are going to be adding the venous blood gases to like our post-op order sets or like admissions for like an Impella order set?
I wonder if Donita's there.
I'm not sure if Julie's on here either, but I was just wondering.
I think she was off. I don't know if it'd be a problem to get it, just because you would just have to draw once, and you really should update it once a day to have the best signal on the continuous. But think about it this way. So you guys, Edwards discontinued the Swan that you guys did have. So all of them have the SVO2 capabilities. I mean, it's a decent price difference. So if you're drawing SVO2s constantly, I don't know how you guys do it. If it's like every 4, some places are like that. It's pretty pricey to send those down to the lab. If they just draw 1 a day, then you can have the continuous. One thing to note about the continuous though, if you're not used to seeing it, it might alarm you, because when you like suction a patient, when you turn a patient, anything that's making them use more oxygen, it's going to drop your SVO2, and in your really sick patients pretty significantly. It'll come back up pretty quickly. It'll take a little bit longer for those really sick ones, but that's normal. That's just what our bodies do. Or if we're doing things to decrease oxygen consumption, like if you're sedating a patient, giving pain meds, things like that, that's going to actually increase that number. So just it shouldn't jump around a lot if your patient's just sitting there, but when you're actually doing interventions, you might see that number change, but just don't get alarmed about it. Cardiologists usually like SVO2, so I'm not sure. I wish I could answer your question, but I bet you a lot of them don't even know that they have it. So
If you have a Dr. Ramon patient, he'll order them Q4. Him or Amanda should put that order in. And if you have a Dr. Xenopoulos patient who doesn't put any orders in, he is good with you ordering them for him. He just doesn't remember to do it.
okay.
I just had a Dr. Xenopoulos patient yesterday. That's the only reason I know that.
Gotcha. Good to know.
Yeah, he usually doesn't mind. I'm thinking more of like for the cert, like the post-op heart.
Gotcha.
When Hannah
It'd be
comes
nice
back, like if they're okay with just adding it into our post-op order set, just so that we like already have that at hand, so that we can just get that first one just to calibrate. And then yeah, this is cool.
Yeah, it'd be nice to have, especially it's already, I mean, if you guys have a Swan that doesn't have the little clip on it that has the capabilities of this, they're just using up what they already had. But all of them should from here on out be the SVO2 Swan. And I know you guys don't use FlowTrack very much, but I'm going to go over it just because one of the reasons we updated this was to use FlowTrack more. So any arterial line, you can use FlowTrack. You don't need a central line. So hold on now. I just went up here to the top left to switch the technologies. So I'm going to switch. Yes, I want to switch. Okay. And then this is what your screen looks like. You can hit 0 up here, or you can actually hit 0 on the where you plug in the transducer to the monitor. So you don't have to actually touch the monitor. So the buttons are the same. The one thing I will show you that's kind of cool. I want some, okay, we have some info at least. So that fluid responsive test you are going to have on here. So fluid responsive test, it walks you through doing a passive leg raise or a volume challenge. So if I'm going to do, I'm not a fan of passive leg raise. Either one though, you can click on it, hit start baseline. So it's going to have you, set the patient up 45 degrees. It's going to give you a 1 minute countdown. What it's doing is getting a baseline stroke volume. So your mLs per beat coming out of your LV. Because when we give fluid, we want that stroke volume to increase because the fluid we put into the heart needs to come out. And that's what we're looking at with stroke volume. So if that doesn't increase by 10%, your patient isn't volume responsive. So you can do a passive leg raise, or you can give a 200 cc bolus quickly. So over 5 minutes ideally. So either pressure bag or a really good central line. Should be good if it's in within 10 as well. But if you don't have that 10% increase, more fluid isn't going to help. So say they order a liter, you would have known in 200 whether it's going to help. So we don't, over resuscitate our patient or, drown them. We don't like to do that. I'm trying to show you guys what this looks like next. Okay, so then I would hit, it gives you your baseline. Hold on, guys. Bear with me. That's why I silence everything. Okay. Might make me do, oh no. All right, do you guys have questions while we wait on this 1 minute countdown? Take that as a no. A couple things about FlowTrack. If you're using it with an Impella, it's not like the numbers that you're getting aren't really including what the impella is flowing. So your patient's going to look sicker because it can't see the flow from the impella. Because FlowTrack works from the arterial waveform, that's just looking at native function. So when you wean your impella, your numbers should get better. So most of the time I would just use it to wean. Say your patient, you know, has an infection or they're trying to get rid of lines and you don't have a Swan, it's nice to wean impellas. Same with a balloon pump, but you have to put your balloon pump on pause to get your numbers, just because it creates that bunny ear waveform and it's going to give you crazy numbers or none at all when you use it. So I'm gonna hit start. So after it counts down, it's going to give you a 2-minute countdown. So you're at this point, you're holding the legs. And then after that countdown, it's going to tell you if they were volume responsive or not. We don't need to actually go through all that. I just wanted you guys to see what it looks like, because that's kind of why, one of the reasons we wanted to update this. It already marks it up here on the graph screen. So you can do that where you look at your percent change, but that it's also going to tell you on that volume responsive test what your change was. So we didn't have a change. I'm trying to think what else to do with FlowTrack. If you want SVR with FlowTrack and you don't have a CVP, you can enter one here. You would just click on this and you would enter a value. And just so you guys know, so like if you make up a CVP, right now this patient has a CVP of 14, SVR is 1269. Say their CVP is really, let's go with 16. So we went to 1214. Let's say it's 20. 1103. It doesn't have a big enough effect not to use SVR, because you can still trend your numbers and you're going to see a patient going septic much faster than if you weren't trending these numbers. And we're going to set up some hemodynamic classes too, so that we can kind of go deeper into how to use these parameters, different things like that. FlowTrack does update every 20 seconds. So if you're titrating anything, it's a good thing to have, because you're going to see it much quicker on how well your patient's handling it.
Hey, Danielle.
Yeah.
Could you go back and kind of look at, somebody sent me a message and they're interested in that PLR and they're wanting to see that all the way through to see what that looks like. And if they did do a fluid bolus, what that would look like.
Okay. I need more to talk about. What kind of, does anyone have any questions? Because this is going to be another like few minutes watching it go through.
So would they have to manually put in the baseline measurement if they did the PLR?
Nope. When I just hit start baseline, that's what it's doing right now. So it'll count down. It's a minute, and it's the same with the volume one as well. Once it actually counts down, it'll tell you your baseline stroke volume. And then when you're done, it'll give you the percent change too.
I foresee that we will have some physicians who will want to start using this once they learn that we have this technology available.
We'll need to get together today, Donita, on how we make them learn that they have it available. All right, so start. And once I get with Julie, would you guys rather it be in person? I'm actually using my simulation. I have simulation where we can actually look at different patient scenarios, whether it's cardiogenic shock, sepsis, different things, hypovolemic, and you can give them volume pressors, things like that, and see how, what you normally look at. And then if you're adding things like this in on how everything changes, would that be something you guys would want to do virtually or in person?
I find that maybe virtually would be better, so that way we could record it and use that and for the staff to use as a reference.
Okay.
And for the providers too, if we can't catch everybody, then I could send them that video and they could see that themselves.
Okay.
Can we do it in person and record it?
Yeah, we can even, I mean, we could do both as long as it's okay with, you know, Donita, and I'm not sure what the rules are still on education. I like to do, I mean, I'll do both. I like to do in person as well. I think people ask questions more, things like that. And I like to write on a whiteboard a lot.
I'm fine with the in-person as well. Maybe we can, after this, it'll be one more thing me and you can kind of schedule.
Yeah, for sure. We can do it. Oh, you know what? Let me go back here. Let me give some, I might be too late. I should have made him respond. That was too late. You can see it starting to climb now because I just gave this patient volume. We can do a regular volume challenge so you can see it, but there wasn't a change because I didn't do anything in the simulation, but that's what it would look like. It gives you that % change. So let me go back. Let's see if I can do it with the volume real quick. 5 minutes is my. Actually, I know this patient won't be volume responsive anyways. Do you guys want to see what it looks like when they're responsive?
Yes, please.
Okay, let me change a couple things here real quick. It's gonna look weird here for a second. Okay, should be able to do it now. So let me go to volume responsive test. We'll do a fluid bolus, get our baseline. I'm a big flow track fan just because, and we'll do this in our hemodynamic class, but if we're worried about blood pressure, the things that make up blood pressure are your cardiac output and your SVR. So if we're worried about blood pressure and we have an A line, it's nice to have more information so we can see the root cause easier rather than, you know, trying fluid. Now we're going to try pressor and then we find out, you know, it's a cardiac problem. So just, it helps you treat your patient's underlying issues faster. Okay, get my baseline. Okay, so now I'm gonna start. Oh, we got 5 minutes to chat, guys. Okay, so let me get some volume here. Should have done a PLR. Does anyone have any questions on like when you can and can't use it? I've heard a myth about some people think you have to be on a ventilator to use FlowTrack, which is not correct. Same with the central line. And AFib, you can use it in AFib patients as well. Wish I could speed it up. I can also show you guys too without, because you don't necessarily need this fluid responsive test. You can, our baseline stroke volume was 34. So we need a 10% increase. So if you're like me, especially after a long day, I don't want to do even 10% math. You should put a decimal between it. Okay, so I need a 3.4 or a 3-point increase to be volume responsive. So if I went to 37 of a stroke volume, I'm volume responsive, which you can see right here that I'm volume responsive in this patient. The very volume responsive patient. Do you guys want to see this all the way through?
No, that's good. Thank you. I get it.
Okay, cool. I can show you too in my favorite screen. Hold on. And see, it already actually told me 26% increase. So that's how it's going to tell you on this. But you also, if you are on this graph screen, hold on. So I think this is where we started, yeah. So it'll also do it on this graph screen to where you can see what your percent change is. So you don't have to go in and do the fluid responsive test if you don't want to. You can still do it this way. So you still have that 26% change in your stroke volume value. It's really nice too to mark interventions because sometimes, say the provider did order a liter, but you have this on, you can still do it yourself and give them 200 or give them a passive leg raise and show them, hey, I did it and I wasn't actually volume responsive, so that maybe you don't have to give that patient more fluid and buy them a ventilator. That's mostly what I have to show you guys. Are there any questions? And I'm going to make sure you guys also have my number available so that you can call with any questions, stuff like that. We did have last night when I was there, I wouldn't communicate with the monitor, and that's something that I did after I updated it. If for some reason it doesn't communicate with your monitor again, please let me know because it's a really quick fix. It should be fine because I've changed all of them, but if it does happen, don't get frustrated. We can fix it. All right. Well, thank you guys very much. If we don't have any questions, I mostly just wanted, this was to go over what the new look is so that when you turn it on, it won't be something completely foreign to you.
I appreciate you, Danielle, taking time to do this.
Oh yeah, you're welcome. And I'll see you here in like 30 minutes.
All right. I'll see you then.
All right. Thank you guys.
Bye.
Thank you.
You're welcome.